This is 1 month post-operative traumatic injury with the cricket ball in a young boy. You will notice a 210-degree iridodialysis, a fibrosed adherent cataract with posterior synechiae, and a fibrosed bulge of vitreous knuckle approximately 11 o'clock position. Now, first of all, we will need to break the synechiae and we would attempt to repair the iridodialysis. Now, once we try and break the synechiae, I notice that there are adhesions there and they are vascularized. And the moment I try and break the adhesions, the blood starts oozing out. Now, the trick in these situations is always try and break the adhesions from center towards outwards. If you come from outside towards the center, you will increase the iridodialysis. This has to be very gentle, controlled, and creating a cleavage plane between the fibrotic capsule and the adhesion. If you pull hard, you could end up puncturing the capsule and creating a capsular tear which may go radially. You will notice in a very controlled manner, I break the synechiae and then do a sweeping movement to ensure that the complete synechial lysis has happened. Once I have completed the synechiae, I now proceed to make sure that there is a mobility of the total area which is torn. Now we do a conjunctival recession there. We create a periotomy, and after doing a decent amount of cauterization of the blood vessels, we will now proceed to create a needle which is bent at 70 degrees bevel upwards and a 27 gauge needle. Now we create a side port with a MVR blade. Two side ports are created here. Now you will notice the reason why I create two side ports. Now using the ILM peeling forceps, I hold the edge of the torn edge of iridodialysis and stabilizing the eye with right hand and the forceps, lift the torn part of the iris, engage it with a needle, and with your 26 gauge needle, I penetrate the iris to create an entry point. Make sure that there are no side to side movements here, otherwise we'll end up tearing the iris. Now from the opposite side of the port, we use a 2-needle proline suture. First part of the needle is now railroaded into the 26 gauge needle, and the needle is very gradually pulled outwards. You have to make sure while pulling the needle you don't damage the endothelium, and also make sure that it doesn't cut through the anterior capsule. Now once this suture has been pulled out, we repeat the same step approximately 1.5 to 2 millimeter away from the first port of the side. Again now a 26 gauge needle is taken behind the iris, and again an ILM peeling forceps holds the tissue of the iris so as to stabilize it as my 26 gauge needle pierces the torn part of the iris. I again pierce the needle through the center, making sure that I don't cheese wire through the torn part of the iris. We have to be very careful because this iris can be sometimes very brittle. Now, while we entering with the needle from the opposite side port, it's a good idea to move side to side so that we make sure that we are not taking any tissue of the cornea or the sclera through this needle. Else, at the last point, we can get stuck up with a bite taken through the tissue. Now, again, railroading the same step. Slowly and gradually, the needle is threaded into the 26 gauge needle, the 10-0 proline, and now the needle is pulled out. Now at this stage, we have created an anchor suture. We tie this suture. We make sure that we don't tie it too tightly, otherwise it might cheese wire through the iris tissue. You can see a knuckle of protruding iris tissue which will be dealt with later on once we finish the surgery. Now to stitch the other part of the iridodialysis, same steps are repeated. An ILM peeling fine forceps goes through the peripheral part of the tissue. You could see that I had a sudden entry into the anterior chamber, and my fear was that I might have cheese wired with the first suture given, but luckily I was safe. Now again, inserting the needle after side to side movement. This is a very important step. If you don't do side to side movement, you can land up with a tissue bite through the main wound. Now again, railroading the 10-0 straight needle into the 26 gauge needle, pulling out one part of the needle, then again the second part of the needle. Now mind you, this is a 2-needle suture which has 2 needles on each side. Again, now the middle part of the iridodialysis will be brought. So mentally you need to divide the total part of the iridodialysis into 4 segments at least, where 2 anchor sutures are going to go. Again, the bite through the tissue of the iridodialysis is taken, needle is moved side to side, and the needle is now threaded by railroad technique into the 26 gauge needle. Now, having done so, major part of the surgery is over. Now, the next thing we will need to deal with is doing a capsulorhexis through a fibrosed, thick calcified capsule. Now, this again, suture is tightened. Again, a reminder, the suture should not be tightened too much. Right now, the pupil may look a bit asymmetric, but that is not a big problem. It can be settled later on, which we will see once the surgery is over. Now we make sure that the knots are given in a manner so that they don't open up and they are not loose. We will see that the suture is trimmed, and now we proceed to remove the pigment which is sticking onto the anterior capsule. Having realized that this is an adherent pigment and it is not going to come off, we decide now to proceed and finish the surgery. Now here you will see that I put some dilator drops to have some kind of dilatation which gives me a good visibility. Now we zoom in, instill viscoelastic and proceed with doing the capsulorhexis. You will notice that the capsule is very brittle, hard and firm and fibrosed. My attempts to cut the capsule in the center are not successful. I slightly increase my main wound now. And now I initiate the first cut through my cystitome bent needle. I proceed to extend the capsule around the fibrotic part of the capsulorhexis or the anterior capsule. Now you will notice the moment my capsulorhexis hits that fibrotic part and counters and adherent. Now this adherence is very tricky. You should be very careful while managing this part, because sometimes if you pull suddenly, you might have a peripheral extension and you could land up in trouble. Now, very carefully, I will try and break these adhesions and take care of the torn part of the capsule, and very controlled movement, I try and create a capsulorhexis. You can notice that my capsule is now totally stuck up. The rhexis is not extending beyond a point. I instill viscoelastic, again try and break those adhesions between the anterior capsule and the cataract. But since it's a very thick fibrotic part, I decide to go in using the micro scissors to trim the capsule from that area where it is adherent and fibrotic. I do create a nick and now try to extend the capsule from opposite side to complete the capsulorhexis, but in vain. So then I finally decide to use the side port to cut the capsule with a bent 23 gauge micro scissors. And I actually end up trimming the capsule away, this fibrotic band of capsule. Since I am not able to complete the capsulorhexis, I complete the capsulorhexis using the scissors. Now, since this is a very soft traumatic cataract in a child, we don't need to do phacoemulsification here. I will proceed to remove the cataract very carefully. You have to be very careful when you're doing this, because at times you might pull up the tag of the capsule which has an appearance of cataract and end up having a peripheral extension. Now, before I finish the case, I always instill viscoelastic in these cases because if you remember, there was a protruding peripheral knuckle superiorly at 11 o'clock of the vitreous coming in. Luckily, till now, we have not had vitreous coming from that part of the wound. The subincisional part of removal of cortex is completed. There is a little tag of thick fibrotic band of capsule which is lying there. Now, before again I come out of the wound, I instill viscoelastic. Now, I proceed to implant the IOL within the capsule bag, you'll notice. And now I dial the lens into the bag. Now, once the lens is inside, you will notice that the lens takes place. It is well placed within the bag. Now, I will rotate the lens so that my haptic now points towards the area of subluxation where there was a vitreous knuckle coming out. So this actually starts acting like a capsule stabilizing part. So the maximum part of my haptic length diameter is facing the area of subluxation of the bag. Once the IOL is in place, I instill some miotic agent in the eye and the pupil will start getting small. Having done that, now I create small amount of pull onto the iris so as to make the iris round in that area. You will notice that most of the viscoelastic has been removed. Now, before I remove my irrigating instrument, I hydrate the wound in this particular case. Since the wound is being stretched for some time, there is a little tendency for the wound to leak. Now I will suture the main wound. Now, since you notice that the eye is practically looking normal, just for the exception of one area of peaking of the pupil, the reason for that is there is slight amount of iris tissue protruding from that part of the wound. Now I decide to reposit that part of the iris which is coming out, and you will notice that the moment I do that, my pupil starts looking nearly round and normal. And once it has been pushed in, you will notice that the eye starts looking practically normal with nearly round pupil and the iridodialysis is repaired and IOL in place. Now we proceed forward toward the closure of this particular case. Now we will just fast forward the whole steps. We will suture the conjunctiva back to the sclera over the wound and cover the sutures. Make sure these sutures are covered properly, otherwise they can start protruding later on and cause irritation to the patient. The sutures are trimmed and made to be covered. You will notice I do a meticulous covering of that area, and once the surgery is over, you will notice that this patient looks nearly practically like a normal case. This child did very well and he recovered a vision of 6/12 unaided and 6/6 parts with glasses with an astigmatism of 1.75 diopters. I hope you like the video. Thank you.